I just wanted to give a big thank you to Carol Marcello, who has been our fearless leader of medical grand rounds, and I think just done an amazing job of sustaining this effort right the way through the pandemic. And in fact, we've had actually a very good turnout during the pandemic at grand rounds, and I think that's due to your skills, Carol, and your ability to bring us a really great content. And I certainly thank all the division chiefs as well for their input into grand rounds, because this is really our premier education event of the week. And you know, I want to keep this vibrant, and I want everyone to keep coming and give us your suggestions. I'm also pleased to announce, as Carol's moving on to other leadership roles in the department, that Christian Bergman, Assistant Professor in Geriatrics, has kindly volunteered and accepted the offer to become the Grand Rounds chair going forward. I think Christian comes to us with, you know, a great background for this. You know, as you know, he works in both acute and long-term care, but has a really national networking reputation, and I think will just bring a wonderful general medicine angle to Grand Rounds. He's going to put together a steering committee, so we'll be hearing more from Christian on this, but really looking forward to the way he's going to shape Grand Rounds, and I know he and I will welcome everybody's input as we continue to develop Grand Rounds into the future. So I want to thank both Carol for her amazing service and the work she's done, and I really look forward to working with you, Christian, and congratulations on the competitive application for this. Look forward to great things in the future. So I just wanted to let everyone know we were changing the baton a little bit for Grand Rounds. And with that, I will let Dr. Nephrology's Gipson and Todd take over.
Thanks, Dr. Stein. So it's actually my pleasure to introduce Graham. Most of you know him very well. He is part of our division. Will be an assistant professor as of July, and started his education as a engineer, a biomedical engineer from Vanderbilt. He did his medical school training at University of Tennessee in Memphis, and came to us as a resident in internal medicine and did his fellowship with us as well. He was one of the early rising scholars in our Department of Internal Medicine, and has been doing research in a number of things, one of which is what he's going to be talking about today, about cholesterol dynamics and chronic kidney disease. He is, during these couple of years, he's really matured as a researcher and as an educator. He's been very instrumental in the nephrology part of our physiology camp. And so he's been an active participant of that, and has been very important in generating those modules. And he's also going to become a core educator as of July 1st as well. So it's my pleasure to welcome Graham, and looking forward to his talk today. Thank you.
All right, thank you very much. Let me switch screen over here. All right.
You actually have to share your screen from.
Oh, you're right. I'm not good at Zoom. Sorry, still not somehow. I'm gonna share my screen. There we go. Thanks, Thomas. Aha, I think this is better. Okay, so thank you everyone for coming out, even though I can't necessarily see how many of you there are. It's a great honor to be asked to talk about my, at least some of my research, which as the slide here says, is in cholesterol pathodynamics, just kind of a name I made up for it. Sounded the most descriptive. And this is really, it's actually kind of more of a cardiology talk in the guise of a nephrology talk. So there's a significant crossover in the research I do between atherosclerosis and CKD, and then some basic science work, and that will come out throughout the talk. So as far as disclosure go, nothing here, but not being fueled by industry or have any other sort of disclosures that I need to make. And right off the bat, I want to give my thanks to everybody who's been at least proximately instrumental in my development over the last few years. And I'm sure names are left off of here, but I've grouped these acknowledgements by those who have helped me as an academic clinician in general. And those are primarily my mentors, the doctors Ghosh at the top, both Shobha and Sid. Dan Carl, who is used to be here at VCU as a program director for nephrology, is now over in the Pacific Northwest, healing kidneys. Dr. Guerra, of course, Dr. Abate, and Dr. Syme. And these last three entries here, the key folks for the Department of Internal Medicine Rising Scholar Program, which is what allowed me to continue this research work that I actually picked up during my fellowship and bring it to fruition and keep growing it. So definitely appreciate that. And then, of course, everybody who was involved in the research that's going to be presented in this presentation is listed on the other side. So big overlap, but also shouts out to Dave Dixon from Pharmacy, Salvatore Carbone, and I think he's a cardiometabolics guy, is the best word for him. Dr. Jovens in cardiology out of the VA, and Jing Wang works with Dr. Ghosh in her lab. And then, of course, all the patients who graciously furnished their plasma for our experiments. So here's a clinical problem that we deal with. CKD patients die from cardiovascular disease, which sounds kind of weird because you would think that CKD patients die from their kidney disease, but really it's the cardiovascular disease that's the major source of mortality for these patients. And that is patients who have even the slightest whiff of CKD to those who are already undergoing dialytic therapies. And so what I focus on in my work is vaso-occlusive CVD, or atherosclerotic cardiovascular disease, which is foundational to all other CVD events in the CKD world. And that's what this weird looking triangle shows, is that on the far left, when you start with no kidney disease, you have, well, I guess, some reference level of cardiovascular risk. Then as you progress towards stage 2 or 3, you develop risk of atherosclerotic cardiovascular disease in all of its many manifestations, as coronary disease, cerebrovascular, peripheral vascular, those sort of things. And then as you advance in CKD stage, from 3 onward, you start to accrue risk of other non-atherosclerotic cardiovascular morbidity and mortality. But that atherosclerotic component remains the basis for this accumulating risk over time. What the bar graphs show is that there is a direct correlation between your level of GFR and your level of albuminuria and your rate of cardiovascular mortality. So this is population level data. It simply shows that the more protein you spill in the urine and the less GFR you have, the higher risk you have of cardiovascular mortality. So CKD-associated cardiovascular disease shares risk factors with non-CKD cardiovascular disease. And these are what are called the traditional risk factors. I'm pretty sure we all know them. Age, sex, smoking, dyslipidemia, diabetes, and hypertension. Additionally, there are myriad CKD-specific or novel or non-traditional risk factors that get piled on top of the traditional CVD risk factors. And so that's what this wonderful graphic is showing. The traditional risk factors are at the top. I grade them out because we all know them, but this is to focus on the non-traditional ones. It primarily has to do with the fact that chronic kidney disease is a disease of total body chemistry. And if your body chemistry is off, then you're going to have problems everywhere. And it turns out the cardiovascular system is very susceptible to those problems caused by the uremic milieu, whatever that means. So we don't necessarily know why these novel risk factors exist or what the pathomechanisms underneath them are, but we know that they exist. So that's at least a step. And before we get into talking about the basic science, and you'll have to bear with me because there's a lot of exposition on getting to the actual research that I do, we need to understand the pathomechanisms of the traditional CVD risk factors in order to get some idea of what the novel ones are all about. So we're going to go back to, I guess this would have been first year, second year medical school, and talk about human lipid metabolism. And I like doing flow diagrams and boxes. It's the engineer in me. It makes things simpler. So I tried to keep this presentation very visual, visually stimulating. And even though it's a lot of processes we're going to cover. So human lipid biology is punishingly complex on a molecular level, but relatively simple on a systems physiology level. So start with the body compartment, which I've shown here. It's the outer solid rectangle, and the plasma compartment within that. So that's the dashed rectangle on the inside. Lipid will enter the plasma compartment from 2 sources. One is the intestine, or the enterocytes, and the other one is the liver. And so once that lipid gets into the body through the intestine and the liver, it has to be carried in the plasma on something, because being a lipid, it's not soluble in water. And so somebody has to help it along. So these plasma lipids are carried on lipoprotein particles and albumin. I really do albumin a disservice here because it does play a big part in lipid metabolism. And we did study it in our research, but it's not considered a canonical feature of lipid metabolism as we think about it clinically. And so it just gets thrown in there parenthetically, but whole other talk could be given on albumin. So these lipoprotein particles and albumin will then go on to deliver lipids to peripheral cells. So that's any cell in your body that needs cholesterol, which is all of them, because none of your body cells actually synthesize cholesterol except for the liver, and maybe a few exceptions that are escaping me right now. But essentially every cell has to derive its cholesterol either from the diet or from the liver. In converse, peripheral cells also deliver lipids back to the lipoprotein particles and albumin. And then those lipoprotein particles will take the lipids effluxed from the peripheral cells back to the liver. So this is a way of maintaining homeostasis where the peripheral cells are able to know, how much lipid do I need? How much is in excess? What should I send back? What should I take? It's a cell's way of keeping balance. So from the perspective of homeostasis, what we've just described is the concept of internal balance, which if you've ever worked with me on nephrology, you know I go on and on about balance, balance studies. But this is a fundamental thing in physiology. So what internal balance refers to is the distribution scheme of lipids within the compartments that are internal to the body. So as this diagram shows, that's all the movements between cells and lipoprotein particles, essentially. Everything that's within the solid rectangle that is the boundary of your body. We can also speak of external balance, which is a concept that describes the net entry and exit of lipid, not just from the plasma, but from the whole body. So that is primarily your diet, what lipids come in the diet, and then what lipids make it out in your feces. And that's actually, it's more complicated than that because of enterohepatic recirculation. That's for another day. But suffice it to say that external balance is what you eat and what you poop. So I'm going to focus now on human cholesterol metabolism, because when I say human lipid metabolism, what I'm actually referring to is cholesterol, fatty acids, and all those other weird things like sphingosine related stuff, just weird kind of like lipid-based macromolecules. Our work is on cholesterol, and so I'm switching the language up here. So we should really break out lipid internal balance or cholesterol internal balance into forward transport, meaning enterohepatic to peripheral cellular, and reverse transport, peripheral cellular to enterohepatic, with each pathway mediated by its own lipoprotein particles. So in the previous slide, I had the lipoprotein particles all lumped as one big dark circle, but there's actually several flavors of them. So forward cholesterol transport is mediated by apolipoprotein B containing particles, which I've abbreviated as ApoBP. These are chylomicrons, so blast from the past, and their remnants. And then all the DLs, VLDL, IDL, and LDL. And those are liver derived, whereas chylomicrons and their remnants are enterocyte or intestine derived. Conversely, as we'll find out in the next few slides, reverse cholesterol transport is mediated by ApoA particles as kind of a complement to ApoB, even though ApoB plays a role in reverse cholesterol transport as well. So forward cholesterol transport is then further divided into exogenous pathway, wherein dietary lipid is absorbed from the gut and enters the plasma through the enterocytes, and the endogenous pathway, wherein synthesized lipid is secreted into plasma by hepatocytes. So this is just hammering home that there are two different sources of cholesterol in the body. So reverse cholesterol transport, this is where the peripheral cells utilize several transport mechanisms to essentially spit out excess cholesterol that they don't need. And just as a note, I put this gray arrow in going from the liver to the ApoA particles. That gray arrow is to indicate that ApoA particles are secreted by the liver and that their cholesterol content is relatively low compared to other liver-secreted lipoproteins, but they technically still contain cholesterol. So for the sake of completeness, I had to add it in there. The prototype, the major ApoA particle is HDL, high-density lipoprotein. Of course, albumin shouldn't be ignored, but as I mentioned earlier, we're going to anyway. So HDL is the big one here. Now, there's this enzyme called cholesterol ester transfer protein that will move effluxed cholesterol from HDL to the ApoB particles. So this is where things get a little complicated. Then the ApoA particles and the ApoB particles together will return cholesterol to the liver for ultimately biliary excretion once you bypass the enterohepatic recirculation thing. So cholesterol from the periphery enjoys two major transport pathways back to the liver. And there's our biliary excretion. Not unlike forward transport, reverse transport can be broken down into two pathways. Effluxed cholesterol from peripheral cells to HDL to liver makes up the direct pathway. Kind of makes sense. The indirect pathway is the one where HDL is sort of, well, it's not really cut out, but HDL serves as a transition point, or you boomerang the cholesterol around HDL and onto the ApoB particles. All of this was figured out with radioactive kinetics studies, and a lot of it was actually done here at VCU back in the 80s by, I forget the gentleman's name, he's not on the faculty anymore, but a lot of this was elucidated here at VCU, so it's kind of in our history. Very fun stuff. So here's the complete system. So this is human lipid biology in a nutshell. And this is going to be the basis for understanding atherogenesis and then our investigations in regards to the specific research project I did. So we can return to the question, what is the pathogenesis of atherosclerosis in general? So red means bad here. Try to be suggestive with my color scheme. So this is the overall scheme of human atherogenesis. Conceptually, you have to have net positive arterial wall macrophage cholesterol balance in order to get atherosclerosis. And what that means in a pathway scheme is that you have to absorb dietary cholesterol from our good hearty atherogenic Western diets. That dietary cholesterol then has to be carried by the ApoB particles over to peripheral cells, which I've substituted here with arterial wall macrophages, because that's our cell of interest. And that cellular cholesterol has to be allowed to accumulate. And there are several other processes besides just eating a bad diet that potentiate the accumulation of cellular cholesterol. And those are hypertension, diabetes, and smoking. The traditional risk factors. It's those risk factors that mediate the development of endothelial damage, which opens up these macrophages to attack is perhaps not the right word, but increased exposure to lipoprotein particles and their cholesterol content. And oftentimes this cholesterol is modified in some way that, that makes it hard for the macrophage to spit it back out. It's like oxidation and things like that. So cellular cholesterol accumulation, as we may remember from pathology, promotes transformation of these macrophages to their pro-inflammatory foam cell phenotype. And so that the yellow glow there is supposed to be angry, inflammatory. And I didn't included a picture of the gross pathology in case anyone forgets what an atheroma looks like. It's pretty nasty. So this should be familiar to all of us as to how atherosclerosis develops. Once this foam cell gets all worked up, it starts calling in its inflammatory friends, and then this big mess happens, and ultimately there's a plaque rupture and a vaso-occlusive event, and there you go. Then you have clinical atherosclerosis. So now that we've covered the pathogenesis of atherosclerosis, we can talk about what treatments we have available now. And if anybody missed this review article in New England Journal from 2019, it's excellent. So all of these treatments are laid out, but I'll just buzz through them real quick here. So the first thing is always, I guess what we call it is lifestyle modification. Don't eat bad, don't smoke, don't get hypertension and diabetes. You got to address those basic things. But the hallmark of our treatments of atherosclerosis, primary and secondary prevention, is really pharmacologic. And so the first directed treatments I'll talk about are ezetimibe and bile acid binders. So what these two do is they decrease the amount of dietary lipid entering, or in the case of bile acid binders, potentially re-entering the body by the exogenous pathway. We then have the statins, which everybody knows about. So I gave their long form name here, the HMG-CoA reductase inhibitors. And then this guy called bempedoic acid, which was a new one on me. But the idea with both of these agents is that they interfere with cholesterol biosynthesis. And in doing so, they not only reduce the amount of cholesterol that is exported from the liver out to the peripheral cells, meaning the arterial wall macrophages, and that decreased level of intracellular cholesterol in the hepatocytes will upregulate the LDL receptor and make the hepatocyte more amenable to taking up any cholesterol that's then delivered to it from reverse cholesterol transport. So they kind of work in two different ways there. I think bempedoic acid was just recently approved in the last few years by the FDA. So HMG-CoA reductase inhibitors or statins, they work on that enzyme. And bempedoic acid works on a more proximal enzyme called ATP citrate lyase. But again, both of them interfere with cholesterol biosynthesis. That's the take-home point. After those, we have everyone's favorite, the PCSK9 inhibitors. For if you want to make your LDL go to 0, you can take this. What these inhibitors do is they protect the LDL receptor from degradation, thereby promoting reverse cholesterol transport, or at least permitting whatever cholesterol is going to be delivered back to the hepatocyte to allow that to be cleared. And so those are a powerful new weapon in our fight against atherosclerosis. Finally, we have the cetrapibs, and I don't know how many people have even heard about these. They were an ill-fated attempt to bolster the HDL-C concentration. It's something I'm not belaboring in this talk is the good versus evil paradigm of atherosclerosis, of LDL is bad cholesterol and HDL is good cholesterol, because really HDL is kind of a multi-face. It plays different roles. It can be good, it can be bad, it can make no difference. But somewhere along the way, somebody thought, well, raising HDL cholesterol seems to be associated with improvement in cardiovascular health. So let's inhibit the enzyme that transfers cholesterol from HDL to the ApoB particles, which would logically increase the HDL cholesterol content of the HDL particle. Unfortunately, the cetrapibs significantly increased morbidity and mortality by an unknown mechanism, some sort of off-target effect of the drug, and so they never made it. So I just included those out of historical interest, and because we're going to be talking about HDL and reverse cholesterol transport, but it's a no-go on the cetrapibs. So despite all of our therapeutic interventions, reduced forward cholesterol transport to arterial wall macrophages is really all that we are able to target at this point, based on all the therapeutic mechanisms I just mentioned. There's still residual CVD risk, though. So you could do everything in your power to address traditional risk factors, have perfect drug adherence, have a patient be on all the right drugs, and they would still have residual CVD risk. So why is that? What are we missing? So if all the successful drugs we have modulate cholesterol metabolism at the enterocyte or the hepatocyte, and if inhibition of reverse cholesterol transport at CETP increases mortality, the cetrapibs, then where else can we look for novel therapeutic targets? We have to ask the question, what's up with the arterial wall macrophage? What is it doing? So back in 2011, so this is still just about over a decade old, there was a change in the paradigm of how we think about atherosclerosis and some of the mechanisms underlying it. So the recognition of residual CVD risk prompted the study of cholesterol dynamics rather than static measurements of blood cholesterol content. Because it's these lipoprotein particles, yeah, we can measure them, but they're They have functional roles. It's not like in nephrology when we measure creatinine as an indirect measurement of GFR. Creatinine doesn't do anything. It's just trash. And so it makes sense to measure it. But simply to have a quantitative evaluation of lipoproteins doesn't tell you anything about how they're actually functioning qualitatively. That's what these investigators decided to do. And the component in reverse cholesterol transport they decided to look at was the cholesterol efflux capacity of macrophages. And what their work showed was that atherosclerotic cardiovascular disease is associated with a reduced cholesterol efflux capacity. This sort of makes sense because if a macrophage is being filled up with all this modified LDL and cholesterol and being turned into a foam cell, and if it's not able to get rid of that source of toxicity, because they're essentially suffering from cellular cholesterotoxicity, then it would make sense that their low efflux capacity might explain why they're getting all foamy in the first place, because they can't maintain cell level balance. So this is where we come back to internal balance. So that was an interesting finding. We got to wondering though, is this true in patients with CKD also? Because these studies that I've cited, and these are just two of the major ones out of a ton of studies that were done, it didn't really look at CKD patients. And unfortunately, CKD patients have been excluded from a lot of research in general. And so a group of really smart folks decided to ask the question, well, how is cholesterol efflux capacity impacted by CKD? So this is where Dr. Ghosh, Dr. Carl, Dr. Carbone, Dixon, Joven came in. And then I tagged along as a second-year fellow under Dr. Carl and got interested in this work. So, little background. Previous investigations have established the semi-quantitative peculiarities in the dyslipidemia of CKD. So, unlike non-CKD patients, the dyslipidemia of CKD, including patients who are on dialysis, is typified by the following pattern, which I gave in semi-quantitative terms. Their total cholesterol is actually unchanged, as is their LDL cholesterol. The HDL cholesterol is decreased, and the triacylglycerol or triglyceride concentration is very increased. So this is a kind of pattern you see in metabolic syndrome. There's low HDL, high triglyceride. But it's weird because the LDL is the bad guy, right? So what's going on there? Why does it look so strange? This is not considered a typical atherosclerosis promoting lipid profile. So within the nephrology literature, folks started asking, well, what is it that's peculiar about CKD that could be causing problems and explaining why the dyslipidemia profile exists? And so a lot of work went into looking at uremia and how it affects the composition and the function of HDL. But none of the work up to the time that our study was done really looked at cholesterol efflux capacity in CKD patients. No functional assessments. And so the stage was set for us to take a look at these folks. So this is an overview of the research that I'm going to go over. We got this paper published back in 2020 in Kidney International Reports, and here's a graphical abstract. So I'm going to break it down and talk about exactly what we did. So the patients, this is the key part of it. We decided to look at a broad selection of patients. So the only exclusion criteria for our participants was they couldn't be youths. They had to be at least 21 years or older. No MI or stroke within the past 3 months and not pregnant. Otherwise, you're welcome to be enrolled. So we had 7 different groups. The first group was a healthy group, and this is people who had no major known systemic illness, so no coronary disease, no diabetes, no CKD, and no risk factors for atherosclerotic cardiovascular disease. The next group was people who were at risk for CAD, but did not have established CAD. And what I mean by established, and I think my next slide will give all the formal definitions, is they did not have angiographic evidence of native coronary artery disease when evaluated at coronary angiography. And they also had to have at least 1 or more ASCVD risk factors. The third group then were people with established CAD, meaning angiographical atherosclerosis, but no kidney disease of any sort. So that was our cardiovascular arm of the study, and then the healthy controls. The CKD arm of the study had patients of every stage of CKD. We had G3, which is considered mild. That's probably the most patients are considered G3. We had stage 4 and 5 separated out at first, but just for out of recruitment considerations, we lumped them. So advanced CKD is G4 and 5. Then we had patients who were on dialysis, and we broke out the dialysis patients into those who were normoalbuminemic and hypoalbuminemic. So albumin gets its props here. This is showing the importance of it. Not so much because we know that it's a molecular mediator of cholesterol transport, which is good to know, but because of the two major predictors of mortality in end-stage kidney disease. Hypoalbuminemia is one of them, and dialysis adequacy is the other. So it was the confluence of this idea of albumin being a cholesterol carrier and its association with dialysis mortality that made us want to break out the groups like that. So in total, we had 107 patients, 15 in each group, except for the advanced CKD, which had 17, and we were ready to go. I'm not going to belabor all of this, but these are the formal definitions that we used for atherosclerosis, coronary disease, and absence of kidney disease, and then kidney disease. These are all well-established criteria and definitions. So back to the diagrams. This is the system of interest that we sought to explore. Reverse cholesterol transport axis, the direct and the indirect pathways. Now, the most accessible component of the system of interest is the patient-specific plasma, because you can take blood from almost anybody. But that's the easiest to get at, the liquid biopsy, as we call it. Without access to patient-specific tissue, we had to substitute native macrophages and hepatocytes with their clonal counterparts. So on the macrophage side, we use THP1 human macrophages. And for the hepatocyte side, we use HepG2 human hepatocytes. So these were not, to be clear, derived from the patients. They were, they live in a test tube or wherever, little microwell dish. So they're clonal. They should all act identical, have normal function. And yeah, the benefit of that design, of these being such kind of boring photocopied cells, is that we're able to control for variation in patient-specific macrophages and hepatocytes. So really, we've isolated the plasma as the variable in the experiment. And clearly, the plasma, at least from a chemistry sense, the plasma is going to be different across the CKD stages. And there may be something different about it in the coronary disease risk patients and in those patients that have established coronary disease. There's some chemical difference that we don't detect by our routine biochemistries that we do clinically. A limitation of this design that's going to make sense in a moment, though, is that exposure of these clonal cells to patient-specific plasma could change their behavior depending on the ever nebulous idea of plasma-borne factors. Is it something that might induce a cell to change its phenotype as some circulating thing in the plasma? So we only let these things sit for, I think it was 24 to 48 hours of incubation. But that's another thing to explore, is how long does a perfectly healthy, off-the-shelf macrophage or hepatocyte have to sit being exposed to CKD stage 5 plasma before it changes phenotype, if it does. So we didn't look at that, but that is an area for exploration. So the first step in our investigation was to create foam cells using radioactive tritium-labeled cholesterol. And so on the right side of the slide, this is the schematic of what we did. We took the THP human macrophages, added in acetylated LDL, which is extra tasty to the macrophage, with radiocholesterol on top of it. And we made these essentially radioactive foam cells. On the left-hand side is the cell biology, molecular biology correlate which is a hand drawing, you're welcome. This shows how the macrophage would take up this cholesterol and the transport mechanisms involved. That's not really the focus of our work, but there are at least 2 different transporters that can take up cholesterol in the macrophage. And then some of this cholesterol can just come in by passive diffusion, but anyway. So the second step in the investigation was to then expose those clonal foam cells that we made by loading them with radiocholesterol to patient-specific plasma and allowing spontaneous radiocholesterol efflux to occur. So same kind of setup on this slide. We've got the cell biology and molecular correlate on the left and the experimental schematic on the right. So given sufficient time, these foam cells should start effluxing their radiocholesterol into the patient-specific plasma to any cholesterol acceptors in that plasma. And so that's HDL. That's also going to be VLDL, IDL, LDL, albumin, anything else. The serum phase itself will accept some of the cholesterol. So we were looking at total cholesterol efflux capacity. And that's important because previous work in this area had looked at patient-specific plasma that had been modified in some way. It was either ApoB depleted, or there was an enzyme inhibitor that was given that saying adulterated the system, it seems a bit harsh, but threatened its physiologic relevance. So what we tried to do was keep this as close to the in vivo processes as we could in an ex vivo sense without mucking around too much with the natural processes. So eventually in this experimental system, we would reach an equilibrium where the clonal foam cells would efflux as much radiocholesterol as they were going to, and those would then be picked up and distributed by the plasma-borne carriers. So then the third step was to take that patient-specific plasma, we called it the conditioned plasma because it contained radiocholesterol in it, and we exposed the hepatocytes to that plasma. You may see where this is going. Those hepatocytes then are going to take up the cholesterol that is being delivered to them. Now, since these hepatocytes are, as I think I've used the term already, off the shelf, there really shouldn't be any variable in the hepatocyte about, well, how is the hepatocyte going to take it up? I mean, they should be ready with a full complement of transporters and everything to take the cholesterol up. The question is how well are these cholesterol carriers in the plasma going to be at getting that cholesterol into the hepatocyte? So it's a subtlety of the experiment that took me a few months, if not like a year, to understand that we weren't really measuring the activity of the hepatocytes, but more of the plasma and the plasma carriers to deliver that cholesterol to the hepatocyte. So after a sufficient amount of time, the hepatocyte would take up some of the radiocholesterol, we'd reach an equilibrium, and then we could use liquid scintigraphy, I believe, to essentially do counts, radioactive decay counts of both the plasma, the hepatocytes, and the macrophages, and quantitatively figure out how this radiocholesterol, the known amount of radiocholesterol that we added in the front end, had been distributed across the system. And from those values, we could compute cholesterol efflux capacity and the capacity to deliver cholesterol to hepatocytes. So those are 2 big variables. And here's our results. So this is cholesterol efflux capacity across all of our groups. And this has dialysis patients on it. We did not publish the results for the dialysis patients. We only did the healthy patients up through CKD G4 and 5. But I felt I had to include the dialysis patients here because there's some really interesting patterns that are going to motivate future work. So just to get you oriented to this figure, this is cholesterol efflux capacity that I have rescaled all of the data relative to the mean value of the healthy patients. And so our reference line for what's considered normal is 1. We'll keep it easy. The number 1 means healthy. And that's what that arrow is showing. So if we look at the CAD group, these patients have subnormal cholesterol efflux capacity. This is a finding, a recapitulation of the finding that's been known since 2011 when investigators started looking at efflux capacity in coronary disease or in atherosclerosis. This was kind of an expected finding. The unexpected one was for CKD stages G3, 4, and 5, and that their cholesterol efflux capacity is actually supranormal for some reason. And then in dialysis patients, you go back to having subnormal cholesterol efflux capacity. Perhaps a little bit worse than the coronary disease patients. I don't believe it reached statistical significance, but it looks a little bit lower. So that's kind of interesting finding. As far as the capacity of the patient plasma to deliver that effluxed cholesterol back to the liver, there's depression in delivery capacity across the board. So in coronary disease, very subnormal delivery. In CKD stages G3, 4, and 5, very subnormal delivery, and even so in dialysis patients. So, now this last one, this question came up from one of the reviewers in our paper. It's actually a very good question. We need to account for cholesterol efflux capacity's impact on the ability to deliver cholesterol to the hepatocyte. And what I mean by that is, if a macrophage is not going to efflux that much cholesterol, well, then of course the delivery of cholesterol to the hepatocyte is going to be dropped down because these are coupled processes, they're in series. And so if the proximal step has low output, then the next step is getting low input, and so its output will be low, this engineer kind of thing. Anyway, we had to normalize the cholesterol delivery capacity to the efflux capacity, and the same pattern emerged, essentially. All of the groups had subnormal cholesterol delivery capacity when adjusted for the cholesterol efflux capacity in that group. So that's kind of a relief, because otherwise it'd be a lot to explain, any differences. So the major conclusions from this is that under our experimental conditions, which again, tried as much as possible to recapitulate the in vivo environment, cholesterol efflux capacity is subnormal in coronary disease. It's supranormal in CKD. It's not requiring dialysis. It's subnormal in dialysis patients. And then the cholesterol delivery capacity is subnormal for all groups compared to health. Kind of weird. So the hypotheses so generated were that there exists some factors in plasma that depresses cholesterol efflux capacity in patients who get coronary disease or who are at risk for it, but enhances cholesterol efflux capacity in CKD patients, though that enhancement is apparently abolished by dialysis, which to me means that whatever this occult factor is in the plasma could be something that's dialyzable. So that opens a whole other area of investigation. The other hypothesis generated is that there exists some factor in the plasma that depresses the cholesterol delivery capacity in all of these groups. So some common factor that makes the liver not necessarily ignore what's the cholesterol that's being brought to it, but something about it is, something about the cholesterol and the cholesterol carriers is just not as appealing to the liver, perhaps. And so the hepatic uptake appears to be lower. So as far as future work for us, we need to figure out why. We need to be focusing on the cellular level. What is going on? What is it that mediates enhanced cholesterol efflux from macrophages? And what is it that depresses or apparently depresses the ability of the hepatocytes to take up the delivered cholesterol, both in CAD and in CKD? So as of right now, we have a bunch of different theories going on with this and some active research. using animal models. But these are still questions to be answered. I mean, it's a lot of work to be done. We were trying to construct a rodent model of CKD, but it's hard to get rats to become atherogenic. They have a natural, not immunity, but they just don't have a proclivity to getting atherosclerosis. We could use mice, but mice don't do well when you do nephrectomies to make them into CKD. So constructing an animal model that recapitulates the human patients has been challenging, but clearly since we can't take apart a person and get their macrophages and their hepatocytes, it would be ideal to have an animal model to do that with, but running into some challenges there. And then from the liver side of things, we're starting to look at one of the less mentioned apolipoproteins, which is ApoC3, and that is has a regulatory role in HDL and triglyceride metabolism. So I don't have a whole lot to necessarily present on those things today, but this is the foundation of early work that, or work in its early stages presently for trying to figure out what is it on a dynamics level, the cholesterol dynamics level that's causing atherosclerosis, not just in coronary disease, but of course in CKD patients also, which is where I come in. So that's how this was kind of a cardiology talk disguised as a nephrology talk, but it's clearly the two disease processes are very tightly linked. So with that, happy to take any questions. That was like a whirlwind of stuff, lots of information. I don't know how this works. Am I going to hear questions?
So I just sent a message to everybody to use the chat or the QA function feature to ask questions. So
you have some stuff in the chat.
I think if we wait just a few minutes,
sure.
If anybody does have a question, just have them type it out.
I think there are some things popping up. Right?
I don't know.
The notification thing is pinging away.
If you just hover over the top and then go to the more and click chat, you'll be able to see.
Thank you. I tried to anticipate questions and do as much exposition as possible. This is it's a tough presentation to give because it almost leaves more questions than it answers, but this is early work. So thank you, Dr. Gare. From the VA, I believe there is an anti-ApoC3 monoclonal antibody to treat hypertriglyceridemia. I think there is too. I am just delving into the body of literature on that. But I feel like I've come across it. Does it have a name? Oh, it's quite a name. Looks Nordic. Oh, I'm gonna have to look into that. Is this oh, inhibitory RNA. Okay, I did know about those. Yeah, the ApoC3 is an interesting candidate for possibly mediating the abnormal uptake of cholesterol into the hepatocytes. We'll be looking into that. Yes. So to get Dr. Ghosh to thank you. We are looking into uremic toxins and circulating factors in CKD. These have already been explored. At least cardiology seems to be getting all over the stuff before we do. Indoxyl sulfate is a big one. P-cresyl sulfate is another notoriously popular uremic solute. And then there's tons of uremic solutes, but a lot of these are known to modify lipoproteins and albumin, of course, and could modulate efflux and cholesterol delivery just in ways that we aren't aware of yet. So that's an area to be looked at. So let's see, Dr. Mayer is asking, a bit confused, it seems that when you normalize for poor input, that the finding of increased KEC for CKD 4 and 5 was no longer seen. All right, let me go back to that. Okay, so in this is the process that's being quantified here is the capacity of the plasma to deliver cholesterol to the hepatocytes. So relative to the healthy reference level, all of the delivery quantities are low. And so that in C4 and 5, not as low as C3, but still definitely subnormal. When you go in and normalize the delivery data to the efflux capacity, here's that reference line. C3, G3, G4, and G5 are still, on average, quite a bit subnormal, as are the ESRD patients. So even after normalizing or adjusting for the efflux capacity, we didn't see a big change, at least qualitatively, in the pattern of cholesterol delivery. All the groups were still subnormal. It's just that the pattern changed a little bit, but it all still under the healthy level. I hope that addressed your question.
So I am not seeing any additional questions on my end.
Okay.
So I think we are good to wrap up.
Okay. All right. Well, got a few extra minutes here at the end. So thank you, everybody, for coming. So is the theory that CKD is blocking macrophages from participating in reverse transport then? What it appears to me is that, let me get back. So this is our efflux capacity from macrophages. The healthy, get my pen. Thank you. Okay, so our healthy group is right in there. So for patients who get coronary artery disease or are at risk for it, their cholesterol efflux capacity on average is subnormal. But in CKD that's not treated with dialysis, a pre-dialysis CKD, on average, that cholesterol efflux capacity is increased. These are really bad arrows, sorry. And then as soon as you go on dialysis, on average, the cholesterol efflux is decreased again. So not to be too, is teleologic the right word, but it's almost as if the macrophages of CKD are hyper-effluxing for some reason. And then once dialysis starts, they start sub-effluxing. And so I would say then that the theory is something about non-dialysis dependent CKD is stimulating the macrophages to get the ball rolling on enhanced reverse cholesterol transport. But on the liver end, the liver is just not really, it's acting as if it's not receiving any cholesterol to take back up. So at this point, we're just finding patterns that our future work has, of course, has to explain. Don't have the explanations yet, though. All right. Anyone else? Dr. Kathari, anything?
Well, lots of congratulations coming in for a great grand round. So thank you very much for sharing your research, and we look forward to hearing more.
Absolutely. Well, thank you for the opportunity. Definitely appreciate it. And all right.
Everyone for joining. It's a wrap.
Okay. Thanks, everyone.